I'll I thank everybody, and then encourage people to join us using the social media barcode. Is that okay?
All right.
That's right.
Great. Now,
Pierre just texted me that he is ready, so hope he's going to join us soon.
Sure. No, that'd be fantastic, actually. Yeah. All right. We got about 7 minutes. That's fine.
Yeah.
Now, Ying Ho, at the end of the session, do you want to stay on the same Zoom for the brief review of the session and the brief exco meeting, or you want to set up a new Zoom?
What is like?
So we're gonna have the room open for a while for the QR code. So perhaps another line will be better.
No problem.
Yeah,
and
you can do that easily. Yeah.
Okay.
Yeah,
I will
sure.
I will send you a WhatsApp message. Okay.
Okay.
All right. Okay, Pierre. Professor Pierre.
Yes.
All right.
Hello.
Thanks very much for joining. Thank you.
Thank you. Thank you for the invitation.
Oh,
welcome here. I haven't seen you yet. Where are you? Are you
Toulouse?
Showing yourself now?
Yeah.
Hello, Narjit. Najee, how are you? Welcome. Yeah.
Thank you.
Now, in terms of numbers, Erica, we have any update so far in terms of pre-registration?
Okay, wait. Miss Dewi, berapa yang udah daftar ya?
933.
Oh.
That's pretty good. So that will reach your capacity very soon, isn't it? What I've done last few days, I'll send it directly to all the counselors and ask the counselors to propagate. So I don't know, that perhaps one very effective way. So I reach out directly to all the APO counselors in 24 countries and ask them to promote it. So I will do that in the future as well. Great. Now, all the speakers here, Alphonsus Chong, you're here? Haven't seen him yet. No. What about Kotaro? Is Kotaro here?
Yes.
Oh, great. Okay.
Angus? Not.
Angus, not yet.
Angus, not yet, no problem. You're probably having Pierre, I must apologize on behalf of Australian. We have a bit of a fight with the French at the moment in terms of our dumping the submarine project. Sorry about that. It's something beyond my control, okay?
I'm not doing politics, so.
So of course, but we can do a cultural exchange. I think that would be a way of smoothing out some of the hard feelings between your government and my government.
That's right.
Yeah. All right.
Dr. Ma, we have 4 minutes to go. So we almost everybody's here. So I would like to remind again, before the talk of the speaker, there will be a short polls question. Each session we have 2 polls question. So this polls question is designed to let us know what is the level of expertise of our audience. So, and then to buy some time for the speaker to set up everything and to start the presentation. Okay, so the polls question will be led by the moderator.
Okay, that's great. And you would mention that at the very beginning, as soon as I done the introduction. Yeah, Erica?
Okay.
Yeah. Right, no problem.
3 minutes to go.
Is Dr. Alphonsus Strong here yet? I don't see him yet.
He's the first speaker that
Yes, I don't see him yet. Okay.
yeah, text him now.
Yeah, he checked it. He checked my message. Okay.
Okay, thank you.
Dr. Margaret, in case if he has not joined, you can start with Dr. Lin.
Lin, okay, I will.
Perhaps. Thank you.
Okay, we have Dr. Alphonsus Strong already. Hello.
Hi, good evening.
Good evening.
Good evening, everyone.
Hi.
Welcome.
Hello.
Dr. Erika,
Yes.
jam.
Should we start? This is the time, Dr.
Okay.
Ma.
Okay,
Still
go
from
now.
August, not yet.
Are we online?
Okay.
Thank you.
Yeah, we can,
Well,
because he's in the third session, we can wait for him and start with Dr.
we can
Yamaka.
get going. Okay, then. Well, good morning to our speakers and audience in Europe. Good afternoon for our audience in Central Asia. Good evening for our East Asia and Oceania speakers, moderators, and commentators. Welcome to the 5th APOA Henapalim webinar. This is a regular webinar that we conduct on a regular basis. The information I will provide a bit more towards the end of the webinar. To get going, I will introduce Erica to now take over and run the webinar show. Thank you, Erica.
Yes, Dr. Ma. Can we have the welcome video? So we are live now.
Yes.
Can we have the opening video, please?
Welcome everybody to the 5th APOA Hand Upper Limb webinar. My name is Ted Ma. I'm the president of the APOA Hand Upper Limb Society. Good morning to our speakers and audience in Europe. Good afternoon to our audience in Central Asia. And good evening to our East Asian speakers, moderators, and commentators, including Oceania. I would like to welcome all of you to join us for this interesting webinar. And to proceed, I'll ask Erica to now start the webinar session. Thank you, Erica.
Okay, thank you, Dr. Ma. So today, in this lovely evening, we will have 3 sessions of our webinar. The theme is from arthritis. The first session will be started by 2 speakers from hand section. Will be moderated by Dr. Margareta Aryani from Indonesia. And it will be soon followed by the elbow section, which is moderated by me, Erica. And then last but not least will be the shoulder section, will be moderated by Dr. Ming Xiang. Let us start with inviting, due to the webinar interaction, please use the Q&A feature only to ask questions. Moderator will collect and submit the online question in the top right button. You can find the Q&A chat feature, and then the speaker will respond to you to your question. The certificate of attendance will be given if you follow the completion of the post-webinar survey by the end of the webinar. Next, please. So without further ado, let us invite Dr. Margareta Aryani from Indonesia, which is going to start the first hand section. Dr. Margareta, the time is yours.
Okay, thank you, Erica. Hello, everybody. Thank you for joining our APOA webinar today. I'd like to thank the committee for entrusting me with this task. Before we go further into the session, we have a little poll, I believe. Can I see the questions? Mbak Dewi, pertanyaan pollingnya mungkin? Okay, this is question number 1 of the polling. What is your preferred surgical method to treat PIP joint arthritis? Please feel free to submit your answer. And the next question, please. Okay, how often do you operate on PIP joint arthritis per year? Okay, thank you. So in this session about the PIP joint arthritis, we have 2 speakers and 1 designated commentator. Each speaker has 15 minutes to deliver his presentation, and afterwards, our commentator, Dr. Wing Lim Tse, will lead the discussion. Now let's go to the first speaker, Dr. Alphonsus Chong, who will be talking about the volar plate arthroplasty, fusion, or prosthetic replacement for the PIP joint arthritis. A bit about his CV. Dr. Chong is a hand surgeon and associate professor at the National University of Singapore. He has strong interest in surgical education, especially technical skills, and he is currently the chair of the National Residency Advisory Committee for Hand Surgery. He has also written numerous papers in many international journals. So without delay, please welcome Dr. Alphonsus Chong.
Thank you, Margareta. I'd like to share my screen. Yeah, okay, excellent. Okay. Good evening, everyone. Thank you to the committee for the invitation to participate in this webinar, and everyone for attending. So it's my pleasure to speak to you about the treatment of PIPJ arthritis, and a link to the PDF of the slides is given there. So I will quickly cover the sorry, yeah. Okay, so
Dr. Chong, you can start.
yeah, sorry. Sorry, let me just start again.
Okay.
Yeah, so can you hear me now? Sorry.
Yeah, we can hear you loud and clear.
Yeah, so I'm going to cover the PIPJ arthritis and its importance in the hand. Wait, sorry. So the PIPJ is the locus of the finger. It's the joint with the largest range of motion in the hand and contributes an estimated 85% in the grasping capability of the hand. The joint is complex, but at its core, it's a hinge with varying centers of rotation, but also some lateral motion and rotation, which is passive. So besides the bony articulating surfaces, the soft tissue components are also important. These include the collateral ligaments, the proper accessory ones that provide lateral stability, as well as the volar plate and the check ring ligaments that provide a volar restraint to hyperextension. So the most common causes of PIPJ arthritis are post-traumatic arthritis, which is the focus of this talk, osteoarthritis and inflammatory arthritis. And less common causes include gout and infection. So there are different surgical approaches to the PIPJ, which I outline in the following order. The most common is the dorsal approach. And this is shown in the central diagram. And it is centered on in the middle of the finger. And at the level of the extensor tendon, you can either split it longitudinally as shown on the left, or use a distally based V-shaped flap as shown on the right. So the next approach is the volar approach, which is less common. And it is useful for fracture fixation and implant arthroplasty. So with this approach, the whole joint surfaces on both sides can be viewed after you shotgun the joint, and it is shown in the diagram on the right. So the final approach is the lateral one, which is useful for some fractures, and also has been described as an alternative to the volar approach for implant arthroplasty. So soft tissue interpositional arthroplasty is one option in PIPJ arthroplasty. It provides an attractive alternative to fusion or implant arthroplasty, as it preserves motion but avoids all the problems with implants. And because there's no shortening of the bone, salvage with fusion subsequently is also possible. However, it's not widely used now, and the data on it is limited. It requires a good soft tissue and collaterals and relatively good alignment of the middle and proximal phalanx. So it's probably best for patients with a lower demand. So personally, I've done it a few times, but I've been disappointed with both the pain relief and motion, so I stopped doing it. This picture on the right is from a technique from Lin, with one variation using the volar plate to interpose. So Gong and his colleagues use a different technique using the FDS for soft tissue interposition. And the advantage here is that the flip of the FDS can also be used to reinforce the collateral ligament and correct deviation. So arthrodesis is a well-established surgical technique for many joints. In the PIPJ, there are different techniques and different implants to choose from, and range from the top left here using wires for a loop and oblique wire construct, or a 90-degree loop construct, or on the top right shown using a tension band wiring construct. Then we have on the bottom left plates and screws, or you can also use a screw-only construct. So in general, arthrodesis is done from the dorsum, but I wanted to share this case from my colleague. who, because of soft tissue reasons, use a plate and screw construct in 2 digits to do the fusion from the volar side. I just want to cover a few technical considerations in fusion. First of all is the angle of fusion. In general, if there's shortening, you fuse the finger in a straighter position. Secondly, as you move from the index to the small finger, from the radial to the ulnar side, the joint fusion angle generally increases, as shown here in the diagram. Finally, you also should need to consider the patient's needs. For example, a guitarist may want the joint slightly more flexed. Secondly, in order to get an accurate angle, the bone cuts must first be accurate. So I prefer the technique shown on the top right, which uses a straight cut using an oscillating saw. But an alternative is to prepare the articulating surfaces in a cup cone fashion. For example, using a rongeur and a burr, as shown on the bottom right. And this alternative is supposed to be more forgiving for angulation and deviation. From a biomechanics point of view, it is unclear which technique is better. So APOA, in one study comparing 5 different constructs, a specialized intramedullary device and plate and screw construct showed the best strength and stiffness. In an earlier study without plates and screws, tension band wiring was shown to be better in the anterior-posterior bending and torsion forces. In my view, all the techniques work, but my favorite choice for fusion is tension band wiring, shown here on the right. And the reason that I choose it is because it is relatively quick to do and reliable in outcome. In addition, it uses inexpensive implants that are non-obtrusive. So the photograph at the bottom is from a technique paper by Uhl describing the process step by step. Overall, PIPJ fusion gives predictable results. The fusion rates are high, more than 85 to 90%. And surgical complications like hardware prominence, malunion, fracture, and so on are reasonably low. From a functional point of view, arthrodesis gives excellent pain relief. And usually strength is better, typically pinch strength. But this is at a cost of loss of motion. But this loss of motion may be less than what you would expect. In Vitale's paper, they report an average of 30 degrees loss of motion in the PIPJ following arthrodesis. This is because many patients already have stiffness before at the time of surgery. So next, I will cover implant arthroplasty for the PIPJ. And there are 2 basic groups of implants: the silastic or silicone implants shown here on the top right, and some form of surface replacement metallic implant shown here on the bottom right. So firstly, silicone implants, which are available for finger joints like the PIP and NCPJ. They have been used in the PIPJ since 1968 and shown to give good pain relief. So as shown in the picture on the right, it is a one-piece implant. So it functions as a spacer rather than a true joint. But there's relatively good longevity and many patients are satisfied with it. In terms of long-term outcomes, this paper showed that there is good pain relief even at 10 years and patient satisfaction. And overall implant survival rate is about 90% at 10 years. But you need to understand that during this time, the range of motion remains unchanged from pre-op. And on radiography, changes do progress. And this includes progressive deformity, such as in the radiograph shown here, as well as fracture of the implant. But overall removal and rate is about 10%. And some of the patients with fractures will keep the implants in situ. And it is best indicated for older, lower demand patients. Metal implant arthroplasty is newer than silicone, and there are many designs. It gives good pain relief, but despite its aim, range of motion is also not markedly increased. And there are higher complications than silicone arthroplasty, such as infections, squeaking, and so on. So Atkinson said in 2014 that there are currently still limited indications for this implant arthroplasty. Young patients with post-traumatic arthritis, no angular deformity, and soft tissue coverage. So while American and European implants predominate, there are Japanese design implants as well. So I'm more familiar with the self-locking finger joint. It has a modular system with a unique bone anchor that is spread open by a locking screw. So as the screw is driven in, these prongs are open even wider and lock into the medullary canal, giving a strong cementless hold. So there's at least one other Japanese implant available called the Ishizuki Total Finger System. So this is a summary of the arthroplasty options. I mentioned, I covered silicone arthroplasty, metal implant arthroplasty, and interpositional arthroplasty. And my colleague, Dr. Ted Lin, will subsequently cover the autologous arthroplasty options. And these are some of its advantages and disadvantages. For direct comparisons of fusion versus implant arthroplasty, this is not well studied. In my view, both currently have a place in treatments as they are differing patients, different clinical problems and functional needs. Some outcomes that have been studied include pain relief, which are comparable, range of motion, which is of course gone in arthrodesis, and there tends to be lateral pinch strength, better lateral pinch strength in arthrodesis. And as I mentioned earlier, implant arthroplasty gives more late complications than arthrodesis. So in summary, I would say that arthrodesis on the PFPJ is a reliable operation for pain relief and correcting deformity. The main issue is total loss of motion of the PFPJ. Although when you look at functional assessment, it's comparable to implant arthroplasty. So I think the good candidate for these are younger and male patients with strength requirement. On the other hand, implant arthroplasty prioritizes motion and also gives good pain relief, but it must be remembered that motion doesn't really increase and tends to decrease over time. It gives more complications and reoperations. And between the two types of implant arthroplasties, silicone arthroplasties are well established. Metal surface type replacement type implants are still evolving. Thank you very much. And I will just hand over to my colleague, Dr. Ted Lin.
Okay, thank you very much for your excellent talk, Dr. Chung. Just a reminder for the participants, if you do have some questions, please write them in the...
Hi, Margaret, I can't hear you. I'm not sure if you're on. Yeah.
Sorry? Okay,
okay.
just...
okay, thank you.
Yeah.
Yeah. Got
okay.
it.
Okay, we go to the next speaker. The second speaker is Dr. Yoda Lin. Dr. Lin was trained in the Tongkong Memorial Hospital in Taiwan. He got the board of hand surgery in 1999, and since then he has devoted himself to the practice of hand surgery. He also obtained his research fellowship at Mayo Clinic, and currently he's the chairman of the Department of Plastic Reconstructive Surgery at Tongkong Memorial Hospital at Linkou. He has published many book chapters and numerous scientific articles. His main interests are microsurgical reconstruction, such as the shunt-restricted arterialized venous flaps and vascularized toe PIP joint transfer, which he shall be presenting very soon. Dr. Lin, the time is yours.
Okay, thank you. And allow me to share my screen. Okay.
Thank you for inviting me to the webinar. I will talk about biological reconstruction for the post-traumatic arthritis of the PIP joint. There is no conflict of interest for people who need a PIP joint reconstruction. Our goal of treatment is to provide a painless and stable joint with a useful range of motion and provide a procedure with durability and minimal surgical complications, that could be the best option. In the history, non-muscular joint transfer has been tried more than 100 years ago. The joint without vascularity ended up with cartilage degeneration, and finally it was replaced by fibrous tissues. Why the vascularity is important to the joint transfer? Because without the vascularity, the joint capsule cannot produce synovial fluid. Then the cartilage cannot get its nutrition support and cannot survive. On January 13, 1965, Bunke transferred a second MCP joint to the third MCP joint. Nearly full range of motion was observed when he published a paper in 1967. In general consensus, vascular joint transfer is indicated for children. We believe that the included epiphysis in the joint could provide growth potential for the children. In the adults, when there is a contraindication for prosthesis or fusion, there is an indication for the vascular joint transfer. These include the joint without adequate capsule and ligaments, and the joint associated with a large bone defect. For the PIP joint transfers, usually flexion of the joint is not a problem, but extension is. Ian and Berger ever depicted that the most striking problem is the extension deficit of about 30 degrees. Chen and I did a systematic review of the PIP joint reconstruction for the trauma cases in 2014. The extension leg of the PIP joint was even worse. Although several factors are inferred to be the possible etiology for the extensor leg, one issue has never been mentioned before. When we did a PIP joint transfer, the skin pedal usually hided the extensor tendon of the toe. So what we did was to repair the distal and proximal extensor tendon as tight as possible. However, we hardly inspect the extensor tendon of the toes. Actually detailed Since 2009, I started to design the skin pedal to the medial surface of the joint. This allowed me to carefully inspect the extensor mechanism of the toes. Two types of toe extensors were identified during the dissection. In more than 94% of toes, we found the central strip of the extensor tendon was attenuated and looked like aponeurosis before its insertion on the middle phalangeal base. We named them type 1. In about 5% of the toes, the central strip can be clearly identified crossing the PIP joint and inserts on the middle phalanx. We name them type 2. The more we dissect, the more type 1 toes we found in the clinical cases. Type 1 toe could be quite similar to the finger. The extension of the PIP joint needs help from the lumbrical muscle. The extension leg of the PIP joint can be reduced when pulling the EDL and lumbrical tendon together, as shown in the picture above. Type 2 toe is different. Without any retraction of the lumbrical tendon, the PIP joint can be fully extended by pulling the EDL alone. Now we have the idea how the toe joint works, but the condition of each recipient finger could be quite different. To decide how we repair the finger, we have to know what extensor mechanism was left on the finger. For most of my cases, the central strip of the finger was poor in quality. In the first condition, the intrinsic muscle doesn't work. The PIP joint can only rely on the extrinsic tendon. Then we can do centralization of the lateral band. 10-year-old boy, he got a dog bite and infection. When we replaced the joint, the central strip and one lateral band had gone. The remaining lateral band was fibrotic and lost its gliding ability. We centralized the only lateral band. At 3.5 years follow-up, the PIP joint motion was quite good. Although growth of the middle finger could be found, but the growth was actually retarded. If central strip is the only defect of the finger, then the central strip reconstruction will be done during the joint transfer. For the central strip reconstruction, two methods were used. In the earlier days, I used modified stakes procedure, that is to reroute a distally based FDS tendon to the dorsum through a drill tunnel at the midphalangeal base. And then the FDS was woven to the EDC tendon. Nowadays, I will use a simpler technique on the right. The forceps was pointed to the drill hole. A 21 gauge needle was passed through the hole. They will made a suture at the tip of the distally based FDS slip. The tendon was gently pulled through the drill hole at the midphalangeal base. And the tendon was passed between the lateral bands. After that, the periosteum was repaired. Then we make a step cut at the central extensor tendon. And the FDS tendon was interwoven to the central tendon. Here you can notice the tension we met to the extend the PIP joint. And the final interweaving. 32 years female. Her major complaint was pain. She is a nurse and need to help the patient to change in position. Power is also needed for her work. She has central slip injury, but the lateral band was good. I did STEX procedure during the joint transfer. At 2 years of follow-up, the extensor leg was 10, flexion was 75. 93% of native toe joint motion was used. The video demonstrates the test technique. We use circuit wire for bone fixation. The wires pass through the drill hole at the midphalangeal base. Then using the same hole, we pass the 4-0 purlin to anchor the lateral band to the metaphalanx. Suture on the first side, passing the needles to the dorsum on the other side, and suture the lateral band on the other side. Then we twisted the wires, and we will check the alignment of the bony inset. After that, we will suture the toe lateral bands to the periosteum of the finger middle phalanx. And then we tie the anchoring suture to create tendon insertion on the midphalangeal base. And finally, the EDL tendon was woven to the EDC tendon. This lady had a fracture dislocation of the index PIP joint in a motorcycle accident. Patient visited my clinic. The injury was only about a joint. So after 4 months of rehabilitation, the patient could have quite good range of motion. In the worst scenario, tendons at the PIP joint and the intrinsic function is absent, and the toe is type 1, we will do central slip reconstruction. If the toe is type 2, we can repair the EDL to the EDC directly. In this case, the extensor tendon at zone 1 to 3 has gone. The intrinsic tendons were fibrosis. This is one of the type 2 toe. So the EDL was directly repaired to the EDC. We only reconstruct the PIP joint. The DIP joint was left alone. At the donor side, we used the resected finger PIP joint as the bone graft. In some cases, the bone graft kept the length of the toe well. In the others, there was some bony absorption from time to time, no matter what. None of the cases complained of foot function. After surgery, the finger is kept immobilized in full extension for 3 weeks. From the 4th week, the patient is allowed to remove the spring every 2 hours for active motion. After 6 weeks, when the bony union of the transfer joint is stronger, the therapist will add passive range of motion to the joint. We ask the patient to have night sprinting for at least 6 months. Until the end of 2019, we have 58 cases. 10 cases were not followed for more than 6 months. 3 cases failed immediately. Patients were followed for 34 months. 22 cases need secondary revision. The overall preoperative total PIP joint motion was 71 degrees. After the transfer, the active range of motion of PIP joint was 60 degrees. All the cases have been followed for more than 2 years. The active motion of the joint maintained well when compared to their performance in the first year. The longest follow-up case in my series was a case with severe crush and degloving injury. He came to me for his index finger. Joint transfer was done in 2009. After the surgery, he went back to his original work as a warehouse management. He needs to have heavy lifting frequently. During 10 years follow-up, not much difference can be noticed of the index. In general, I will use the same indication for the vascular joint transfer in the composite defect and in the children. Personally, I will recommend the use in the middle finger and the ring fingers, which are more important for the grip and the reduced quadriga effect. Of course, the patient has to be aggressive. We believe the keys to improve the PIP joint transfer is to inspect and reconstruct the extensor mechanism at the same time. Technical details have been published in 2019. So my conclusion, vascular joint transfer can provide a composite reconstruction of the joint and potential growth for the children, and do joint transfer for the patient with good compliance. And remember to reconstruct the extensor mechanism at the same time. Following this general principle, you can also get a good result of vascular joint transfer. Thank you for your attention.
Okay, thank you, Dr. Lin, for your very beautiful presentation. Now we have Dr. Wing-Lim Tse as a designated commentator. I'm going to read his CV for a while. Dr. Tse is currently the president of the Hong Kong Society for Surgery of the Hand. He is a consultant hand surgeon at the Prince of Wales Hospital, as well as an honorary clinical associate professor at the Chinese University of Hong Kong. Over to you, Dr. Tse.
Thank you, Margaret, for your kind introductions. I do enjoy the two talks very much. May I first, ask a question to address to Dr. Alphonsus Strong first. Dr. Strong has already answered most of the questions in the chat box. I would like to challenge a challenging question. Now we're talking about arthritis. What about when we're viewing difficult situation in a pilon fractures of the PIP joint? Yes, and this kind of situation, I think the armamentarium that you are using, like the volar arthroplasty, joint fusion, and even the implant arthroplasty will be helpful and be indicated in this kind of patient, particularly when they're young. So would you consider these options in these difficult cases in non-salvageable PIP joint fractures, like the pilon fractures?
Yeah, I think pilon fractures are difficult, and the options you mentioned definitely are possible. Sometimes it is there's a big volar fragment and there's some dorsal subluxation. The other option that we didn't really talk about is like a hemi-hamate transfer. I think that would be a favored option, particularly if the patient comes late and it is hard to reduce. For some of these pilon fractures, what I have found useful also is to put a external fixation type device, like a Suzuki traction, which uses wires and dental bands. And you can then do open reduction and try to get the articular surface back with or without additional fixation, and try to mobilize the fractures early. Those are some of the alternatives for the bad pilon type fractures to consider.
Yes. Thank you. While volar arthroplasty as another simple biological options for salvaging the PIP joint, actually, I think what is your view on whether this is actually maybe applicable for young gentlemen instead of a low demand old gentlemen? Because it seems has intermediate options that we did not burn the bridge for the patients for subsequent options like the fusion or implant arthroplasty.
Yeah, Dr. Say, I think definitely it is true. It is a possibility to discuss with the patient this interpositional arthroplasty. Although in my own cases, I haven't found it to be that it doesn't give that much motion. But I think it is helpful if the patient is not ready for arthritis, not ready for arthrodesis, and doesn't want an implant inside. A lot of my patients, though they are manual workers, and the younger male manual workers, they often want like one surgery to solve the problem, and to me that often tends to be arthrodesis. Yeah, I'm not sure. What do you have what is your own experience with interpositional arthroplasty?
Yes, for young gentlemen, I've usually quite difficult to discuss with them the option of fusion, even though I know it's good for them. But sometimes, particularly the middle finger, is quite difficult for them to accept a fusion. So I think molar plate arthroplasty, I'm now getting more interest and also more experience on that as an intermediate solution. I think because it's as an intermediate fingers, sometimes they can spare a little bit of the forces. Using the middle and ring and the little fingers, while the middle finger may be more on some fine manipulation, etc. And also can be the workload can be shared by the index finger actually. So I think to me, now it's quite some cases that the patients will be happy with this intermediate solution and not yet demanding for more definite treatment. And also, when they're getting middle or more advanced age, I think the implant arthroplasty is always good if they want to preserve the function. Thank you very much, Dr. John, for your sharing.
Thank you.
Yes. Margaret, may I now adjust questions to the, Dr. Lim, or should I ask questions to Dr. John? Yeah?
Yeah.
Yes, okay. Yes. Dr. John, thank you very much. I enjoy your, Dr. Lim, I enjoy your talk very much. It's very exciting. And then you demonstrate very good techniques in the design of biological vascular toe joint transfer. I see there's some, I know that it's expected that we know that there's some complications following this kind of very complicated procedures. But yes, certainly, for example, growing children, patients, there's a very good options for them. I would like to ask, how would you manage, there would be some cases that you would like to have some revision to improve the function. What would be the indication for doing revision surgery for your cases? And if they really need that, what's the time frame that you will consider surgery? Thank you very much.
Thank you, Dr. Chen. I think, first of all, I have to differentiate that I have two problems in the cases that I need to do the revision. One is for the bony alignment, because the toe joint, although it's a like tissue to the finger joint, but the shape of the joint actually could be different, especially could have that kind of difference between the persons. It means that every joint could be different. So when you put it on, insert it to the finger, sometimes you thought the alignment, you double check the alignment is okay, but maybe the fixation problem still make the inset joints kind of unstable, easily to have some hyperextension of the proximal phalanx level. The wiring is not as easy because the diameter of the toe proximal phalanx actually is much smaller than the finger proximal phalanx. So kind of difficult when I do the insert. Even I use 90-90 wires, sometimes still will lose some of the reduction. So this especially happened in my earlier days of joint transfer. So I did more bone revision at the earlier days, but recently it can be reduced with the refinement of my inset. And secondary, when I need to do the revision for the motion, that for some patient that after the surgery, probably you can, because, well, even Taiwan is a small island, but for some patient that to travel a long way, probably 2 hours or 4 hours from the mid-south of the Taiwan to me, they are too far from my clinic. So they have the rehabilitation at their hometown, but well, I think, well, it's a complicated procedure. So the rehab definitely have to be very careful and to have a good cooperation with your therapist. So to get a good result. So for some patient that they do have some problem, they cannot meet this criteria. They have to travel a long way, and the rehab may not be consistent or with our protocol. Then they will have to have some revision secondarily for such as joint release or for some tendinitis. But basically, I will, no matter it's for the bone or for the tendon, for the joint, I will ask the patient to have the rehab for 6 months. I will not do anything before that because, well, all the vascularity, all the inflammation actually was not settled down before that. So I will ask the patient to continue in the rehab. And after 6 months, if the range of motion actually is not our expectation, for some cases that I will use the passive range of motion, the toe as a baseline, that at least I know that the preoperative, the toe joint can move from such as 10 degrees to 80 degrees, that's about 70 degrees. If the joint after the transfer is much, you can say less than 80% of that could be around 40 degrees or less than 50 degrees of range of motion, I would say they could have some potential for better range of motion. In that cases, of course, we can provide some revision for them. But of course, we still have lots of cases that the preoperative, the recipient side, the finger injury was too severe, then much more scarring when you do the joint transfer, then you will know that they are not a good candidate for further revision. Then, well, if patient is satisfied with that, we don't provide any more revision for those cases.
Thank you very much. How you manage the donor, the defect or the toe donor?
Yeah, donor side actually is I show that I usually use the bone resected from the finger joint because well, for the toe, if they have the good MTP joint, they walk well, they run well, climb well without any problem. So we just using the bone resected that, well, that is already good enough. You don't have to harvest bone gravity from the other donor side, such as the ilium. So basically, well, if you don't use that bone graft, actually you just throw them to the buccal or to the pathologist, and well, it's useless. But we can salvage that for the grafting, and basically we don't need the whole resected finger joint for the purpose of the bone graft, because as we noticed that the diameter of the toe joint is much smaller than the finger, so probably you just use one half to 2/3 of the volume is good enough for the bone grafting. So initially I was using the K-wire, put them for 6 weeks, but I will not wait for any union of the bone grafted. Actually, just like a spacer. So even without a good union of the bone graft, well, the patient actually still walk well. I do not complain about the some kind of laxity, lax toe. They are fine with that. So I use the bone graft as just a spacer to keep the length. Yeah.
Thank you very much. I think so. May I hand over the questions to the other panelists, Margaret?
Yeah, sure. Are there any questions? If I may, I have a little question for Dr. Yota Lim. Hi there. Well, not all hand surgeons are adept in this kind of microsurgical reconstruction. Actually, I've read some papers on non-vascularized toe phalangeal transfer, which has been used in reconstruction of the hand. There is even one paper that mentions this method for small joint reconstruction in finger. What do you think about this? I know that non-vascularized toe joint transfer has a lot of limitations, but what do you think? What do you think are the role of this particular technique, the indications, and yeah?
Basically, I think most of the people will consider using non-vascular joint graft or some allograft as a temporary purpose. They were just using that for the first year after the trauma. If the patient could not decide to have a definite treatment of that, that can be used as temporary management. But as I described in my talk, that actually I have 3 cases who failed immediately, but I did not remove the joint or amputate the finger. I just leave it there as a non-vascular graft. Those fingers actually, those joints actually degenerated. Just from time to time. They could have some deviation or they have some limited range of motion, but interestingly that because I routinely do not repair the nerve of the finger, the toe joint to the finger digital nerve, so they are not reinnervated. So from all the papers reviewed, actually, for those patients who have some secondary degeneration or of the transfer joint, actually they hardly complain of pain of the joint, and sometimes they still can work with that. So basically, for non-vascular joint graft, I would not recommend it as a permanent treatment. And well, though it might work for those in the congenital hands, well, I'm not sure about I have no experience of that, but well, from some papers from Japan that they show good result without a good do not need to have a vascularity of the joint, but still work well. And I believe that we for all the joint that we still need the vascularity to keep it survive. Could it keep it as a long-term survival for that? Yeah. So vascularity is important.
Thank you. If I may, one more question, sir.
Yes.
You mentioned about, you showed us the picture of your skin paddle. So you took the skin paddle from the dorsal aspect of the graft or from another adjacent toe?
Actually, the skin flap was designed on the tibia surface of the PIP joint, not on the dorsum. So all the dorsum was exposed for inspection and reconstruction of the extensor tendon. So skin paddle was on the tibia side. You also can design on the fibula side, but well, in that case, probably because I use the tibia skin pad, tibia size skin paddle is much more nearby the tibia plantar digital artery. That's a pedicle we use for the transfer. So basically, the skin paddle not only provide the monitoring, but also it can protect those nutrition vessels that are penetrating into the joint. So skin pad on the tibia side, I think that's my way of design. Yeah, thank you.
Thank you. I think we're running out of time. So I think we should close this session. I'd like to thank everyone here, Dr. Te, Dr. Lin, and Dr. Chong. I think you've all done great works. Thank you for your presentation. So back to you, committee.
Thank you.
Okay, thank you, Dr. Margareta, in the hand session. Now we come to the more proximal joint, the intercalary segment. So as I mentioned, elbow joint is not very popular compared to the shoulder and hand, but we'll do our best to entertain everybody. So the total elbow replacement is performed not as routine as the shoulder joint arthroplasty. This session, I will also invite Professor Sumin Cha from the Korea, who is a very dedicated and keen upper extremity surgeon from Chungnam National University Hospital to join us. Hello, good evening, Professor Cha Sumin. So our next speaker will be Professor Pierre Mansa. He is one of the leading elbow surgeons in the world, and who is also the founder of the French Society of the Shoulder and Elbow. He is also the chief editor of the JSCS, Journal of Shoulder and Elbow Surgery International. He is currently the chairman of the Department of Orthopedic and Traumatology in Toulouse, France. We are very honored to have him here with us and learn about him, about his experience, about the current concept of total elbow replacement. Just before the talk, can we have a poll for the elbow section, please? We have two questions. The first one will be, can we start? Okay, how often do you perform a total elbow replacement in a year? I think if you do more than 15, you're a pro. Okay, 5, 4, 3, 2, 1. I'm gonna end the poll, and 90% answer less than 5. So we have less than 5 for a year. That's very impressive. Okay, I'm gonna stop sharing and let's start the next poll for question number 2. What is the most common reason to perform a total elbow replacement in your practice? I give you 5 seconds. 5, 4, 3, 2, 1. I'm gonna end the poll and share the result. Okay, so we have, interestingly, 35% post-traumatic and 30% rheumatoid arthritis. Okay, we are going to start the session. Let's call for Professor Pierre Mansa. The time is yours, please, sir.
Thank you very much for your introduction. So I will share my screen. Okay. Okay, you see my screen well?
Yes, very clear.
So thank you again. So my talk is about current concept of total elbow replacement. So there is I have no conflict related to this talk. There is a long history of total elbow arthroplasty, and it was not until D reported the use of a cement to fix a fully constrained hinge implant to bone that the modern age of replacement arthroplasty was born. So it was around 1970s. However, longer follow-up demonstrate high rate of failure due to loosening. A better understanding of elbow joint anatomy and biomechanics has resulted in improvement in prosthesis design and lead to 2 approaches. In the first approach, the joint were resurfaced with an unlinked implant with preservation of the collateral ligament for stability. Stresses across the elbow were absorbed in part by the soft tissues, resulting in less constraint at the bone cement interface with theoretically less risk of loosening. However, these implants were potentially unstable. These implants could be non-anatomic with a cylindric cylindrical humeral component rolling in the polyethylene of the ulnar component, like the Kudo that you may know, or the IBP. But also there could be non-linked prostheses mimicking normal anatomy, like the Ewald in the US, the Suture implant in the UK and Europe, Sorby in Canada, or a Gepard total abortoplasty in France, some with radial head prosthesis. All of these prostheses are mainly not manufactured anymore. The second approach to implant design was a linked prosthesis, which stability was provided through a linked articulation between the humeral and ulnar components. Modern semi-constrained implants have a slopy hinge that allows a few degrees of varus valgus and rotational laxity, decreasing stress at the bone cement interface. The potential weakness of this prosthesis was mechanical failure. The most popular linked implant were the Kunran-Moray and the Discovery from the US, the GSB3, which was very popular in Europe, designed by Norbert Schwendt, is not anymore manufactured. The main complication of linked implant remain mechanical failure, especially polyethylene bushing wear, necessitating in some case bushing exchange, like you can see here. Another option is to move from an unlinked implant to a linked one with the same prosthesis and the same instrument with a convertible implant like the Latitude prosthesis to be able to choose a better option for the patient. From these experiences, the rationale of elbow implant design has been defined. The total abortoplasty must restore function, be durable and doable. Functional range of motion between 30 and 130 must be recovered after total abortoplasty. That imply ability to release soft tissue to gain extension while maintaining stability of the joint. Linked implants is to better achieve this goal, especially in very stiff elbow after a big release. Biomechanical studies have shown the high amount of forces at the elbow posteriorly directed that compromise stability of the first generation of anatomic implants. So stem implants have been designed and have shown to better resist to these forces. However, it was not sufficient, and with time, loosening of the stem implant occurred with anterior displacement of the humeral stem. Adding condylar support or an anterior flange has shown to limit this complication with time. Most of the design available nowadays have all this type of anterior flange. It is not still clear in literature if a radial head prosthesis must be used or not when doing a total abortoplasty. Previous studies have shown fair results obtained with this configuration, like the Pritchard Walker or the Sorby implants. Theoretically, it can limit valgus forces, preserving the link system. However, this has not been demonstrated clinically so far. Stability of the joint must be sometimes compromised in certain circumstances where there is poor quality of the collateral ligaments, like in a rheumatoid arthritis, loss of bone or deformity. Link implants offer an immediate joint stability because of its intrinsic stability. The theoretical disadvantage was to increase stress at the joint linkage and at the bone cement interface. Little, in 2005, performed a comparative study evaluating 3 total abortoplasties, 2 unlinked, the Suture and the Kudo, and 1 linked, the Kunran-Moray arthroplasty, to treat rheumatoid arthritis elbows. All 3 implants procedure relieve pain. Sustained improvement in the range of motion was comparable among the 3 groups. However, the 5-year survival of the Kunran-Moray implant was better than that of the other 2 implants. It seemed from this study that component linkage with a semi-constrained prosthesis like the Kunran-Moray implants prevents dislocation without increasing the risk of loosening, at least at 5 years follow-up. Same results have been observed and reported at Mayo Clinic after 25 years experience. The survival free of revision of all unlinked implant use at 10 years was 60%, whereas it was 85% for all linked implant use. This curve was especially impressive since 95% of the unlinked implantation were only for rheumatoid arthritis. But in the link group, 55% of the prosthesis was performed for trauma. Reviewing the Danish registry, the authors have shown better survival with link prosthesis, the line in blue on the table, versus unlinked in green, and with the Coral-Murray prosthesis versus the GSB3, the Ewald prosthesis, and the suture arthroplasty. Again, in this Norwegian registry, better survival was obtained with linked implants like the GSB3 or the Discovery compared to unlinked implants like the Kudo or the IBP. In the same analysis, they found a lower survival rate with uncemented implants. Finally, published in GSES last year, coming from the New Zealand registry, this study have shown better result with a Conrad-Murray prosthesis compared to the convertible latitude prosthesis, with the number of revisions with the Conrad-Murray 72% lower than with the latitude. The Scottish registry has outlined recently the degrees of the number of total elbow arthroplasty related to a degrees in total elbow performed for inflammatory arthropathy like the rheumatoid arthritis, while total elbow arthroplasty for non-inflammatory causes increase over the same period. So the tendency is to indication for rheumatoid arthritis decrease, and indication for trauma or trauma sequelae seems to increase. Same tendency has been observed in different registry from Scandinavia. On your left is from Denmark, on your right is from Norwegian, and you can see these degrees of indication for rheumatoid arthritis. Here, another data from more international registry, like here, including the New Zealand data, and you can see again the degrees indication of inflammatory elbows with more trauma indication. If you want to summarize literature about the survival rate of the main total elbow arthroplasty used for rheumatoid arthritis, we can see that for the Kudo implant, the survival rate was around 85% at 10 years. However, you have to know that there were, during this period, there were 5 different types of Kudo prosthesis that have been used a long time. It was 75% at 10 years from the suture and 78% at 13 years for the GSB3. For the Conrad-Murray, the survival rate was 92% at 10 years and 68% at 20 years. I review my first 100 cases of Conrad-Murray prosthesis performed between 1997 and 2008 for various etiology. And where I found that the survival rate was 98% at 5 years and 92% at 10 years, confirming the result of Mayo Clinic. With a decreasing indication of total elbow arthroplasty and rheumatoid arthritis, trauma condition is becoming one of the main indications. For this etiology, a link implant is mainly used, like acute distal humeral fracture, distal humeral non-union, post-traumatic arthritis, and sometimes ankylosing or stiff elbow. The goal of a total elbow arthroplasty that can be discussed in acute distal humeral fracture in elderly patients is to obtain a pain-free, stable, and functional elbow. We reviewed during the symposium of the French Orthopedic Society in 2012 the result of 87 patients of 79 years of average who have been treated with a total elbow arthroplasty for distal humeral fracture. The results were satisfactory on pain level, elbow stability, and function recovery. The Mayo elbow performance score was of 85 points with a quick dash score of 24 points. However, there were 20 complications and 8 revisions. The results of literature are similar with indication for patients around 80 years. In most series, a Mayo elbow performance score around 90 points, a functional arc of motion recovered in almost all cases, and a complication rate around 24% with a revision rate of 11%. Only in series from Mayo Clinic, patients were younger because it concerned a mixed population with patients with rheumatoid arthritis and fractures. In the 2 series from Mayo with a longer follow-up, complication and revision rate were higher, with for the last series from 2016, 5, 10, and 50-year survival rate of 85%, 76%, and 76% for elbow with inflammatory arthritis, and 92%, 92%, and 81% for non-rheumatoid elbows. However, the use of Conrad-More in post-traumatic arthritis has shown the weakness and the limit of this kind of prosthesis, especially in high demand patients with wear of the limb system. They obtain in this series only 70% of survival rate at 15 years, and 75% of failure were observed in patients less than 60 years old. The treatment of excessive wear of the articulation is to remove and replace the articulation if possible. If the implant is loose, it must be removed and changed. However, in most of the cases, the implant exchange is usually not required, like on these cases, when the stem are well fixed. Here, 8 years after the initial procedure from distal humerus non-union. Same kind of result have been published in distal humeral non-union with a survival rate that decrease over time and we reach 65% at 10 years. It seems again in these populations that complication and revision increase with follow-up and was correlated with the number of previous surgery. 16% if there is no previous surgery and 33% if there were more than 2 previous surgeries. Here, clinical cases with a 70-year-old woman with this type of non-union. In 2014, we report our experience of total elbow arthroplasty in 2 groups of patients after previous ORIF for fractures, group 1 with post-traumatic arthritis and group 2 with non-union of the distal humerus. Patients were younger in group 1. At follow-up, better results were obtained in the non-union group with better DASH score and Mayo score. Furthermore, the complication was higher for patients with post-traumatic arthritis with a greater revision rate. In the non-union group, results were comparable to those obtained after total elbow arthroplasty for acute fractures. Here, a personal example of post-traumatic arthritis treated with total elbow arthroplasty with this 14 years results. The pre-cut ulnar component has to be revised at 14 years follow-up because of aseptic loosening without revising the humeral stem. Finally, total elbow arthroplasty can be discussed in kilos or fused elbow if needed. In 2000, I reviewed Dr. Morris' patient. I reviewed 14 elbows that were evaluated at a mean follow-up of 5 years after surgery. As you see, the mean preoperative arc averaged only 7 degrees and 9 of the 14 elbows were totally fused. The other 5 at less than 30 degrees of motion. Diagnosis was mainly post-traumatic arthritis. 8 out of 14 elbows had additional joint involved on the ipsilateral limb. After surgery, the mean arc of motion averaged 67 degrees. We emphasize in this series the development of ectopic bone around the joint, which was observed to adversely affect outcome. We also recorded 7 complications in 5 of the 14 elbows. This includes mainly infection. Overall, approximately 78% of patients were satisfied with the outcome. So total elbow replacement as a salvage for a dysfunctional ankylosed elbow or severe post-traumatic arthritis should be performed with caution. However, the outcome can be reliable, having a dramatically positive impact on patient function and satisfaction. However, with follow-up, the rather high complication rate reflects the limitation of this procedure. Especially the mechanical complication indicates that in younger patients, total elbow replacement may only be performed with reservation and only for those who do not perform strenuous physical activities. The future of the prosthesis will rise from the experiment of the past and the possible correction of the weakness of the current implant. We see right now an increased proposal of implant for degenerative lesion of the elbow, hemiarthroplasty, for limited lesion, especially distal humeral fracture, unicompartmental arthroplasty, and convertible arthroplasty. System for revision could be developed with different stem options, cemented or not cemented, with modularity to deal with different cases of bone deficiency. Accurate replication of flexion axis seems of paramount importance to reach the normal kinematic of the elbow and to increase the longevity of this implant. This can be still improved with development of reliable landmarks, anatomic stent shape, improved instrument, or maybe compute assist surgery. However, there is still a particular weakness of the linked implants is the link system. Different experimentals have been done to minimize link failure with follow-up. In the discovery design, there is a more constrained axle mechanism than the Kruan-Moret prosthesis with a bigger system and the thickest polyethylene. In the latitude system, the design of the humeral component allows to maintain maximum contact with the ulnar component throughout 7 degrees of various valgus laxity of the articulation. The polyethylene of the ulnar component is thickest anteriorly in the rear of the maximum loading. The Nexel elbow system evolution of the Kruan-Moret offers thicker polyethylene bushings and stronger link system. The polyethylene characteristic can be also improved and alternative bearing surface can be maybe found and tested. Decreasing the rate of loosening remains also one of the most important problems with total elbow arthroplasty. It can be performed by improvement of cement technique as well as improved stem design and treatment surface. The use of uncement stem could be a solution and unfavorable bone, but must be proved clinically. Triceps weakness is another problem related mainly to the surgical technique and can be improved. The triceps on technique has been used now to preserve the triceps, mainly in trauma cases. Finally, the infection rate remains the highest after joint arthroplasty compared to other arthroplasty. Many factors could participate to decrease the rate of infection, like the surgical time, adapted antibiotic prophylaxis, and better patient selection. To summarize what have been learned so far, the ideal total elbow arthroplasty must be stem, must be flange, should be linked, must have surface right, must minimize wear, must be flexible, should be easy, and must be cemented, even if uncemented prosthesis could also be another option. Total elbow arthroplasty is now being used to successfully treat elbow conditions that have traditionally been treated less successfully with other methods. However, the complication rate may be high, so careful selection of the patient, preoperative planning, and the experience of the surgeon are prerequisites for success. The future could be a compromise of what have been used so far with some new ideas that has been to be validated by experimental and by clinical data. Thank you for your attention.
Okay, thank you, Professor Mansad, for the very punctual time of your 25 minutes talk. Now we are starting with our discussion session for 15 minutes. And may I remind you the Q&A feature is located at the right bottom of your screen. So do kindly deliver the question through this feature. So let me invite Professor Sumi Cha from Korea to join us with our discussion session. Could we have him pin? Okay. I summarize a couple of things. At least there are 4 worrisome issues we have to think about when we do a total elbow replacement, which are the approach, the implant performance, as you discussed very deeply, and complication and handling the ulnar nerve. Let me start with the surgical exposure. Basically, we have 2, may I say, triceps off and triceps on. So what is your tip, sir, on choosing the surgical exposure in view of the maximizing the articular surface viewing? And in view of that, we also have to preserve the triceps as the most important extensor mechanism to guarantee our successful total elbow. In a revision total elbow, usually these are very severe and thin. What is your comment on the primary first? May I start with Professor Mansat?
Thank you for your question. In my experience, I mainly use the Brian Murray approach. So it's a reflecting triceps approach that gives you, I think, the better view of the articular joint. And what is the most important is to position your implant as accurate as possible. Because if you have a malpositioning of your implant, you will have an increased stresses in your leg system and an increased risk of failure and loosening. So I think the most important is to view the better as possible view joint in order to be able to put your implant in the better position, the more anatomic position. Okay. In some cases of fractures or maybe non-union, where you remove all the joint, you can use a triceps on approach because it's easier to get to the joint because you have to remove all the big piece of joint. And I think it's maybe a good option in this situation for me only, but not really on other cases.
Okay, let's hear our Professor Sumin Cha opinion. What is your favorite surgical approach for a primary total elbow replacement?
Oh, if like Mansa, I prefer the triceps.
The primary approach, so the triceps off, yeah, from medial to lateral. Yeah.
In fracture type, usually I use triceps on approach. Due to have removing the fragment, we have some space during the insert.
Okay, how about the revision case? So in the revision case, usually the triceps is thin. Sometimes it's like a paper. Will you change your approach, or still Brian Murray is the most favorite one? Can I have the opinion of both?
I usually don't change my previous approach in revision case.
Okay, how about you, Professor Mansa?
Yeah, I use also the same approach, and if needed, and there is a thin triceps, as you mentioned, I use the anchor-nails transposition in order to get a continuity of the extensor mechanism. So this could be a good trick to when you have some triceps defect or triceps insufficiency.
Yeah. Okay, let's move to the second question. The implant performance. Implant performance has been a very interesting talk. Perhaps can be driven by some conflict of interest as well. So when we put the non-implant, non-link implant aside, I think at least 3 issues can lead to a total elbow arthroplasty failure which are implanted elbow was not used without restriction, was used without restriction. Patient is too young or too active, or patient with inflammatory arthritis. My question are, what is your threshold of considering this patient is too active for a TEA? So I spent time in Korea. They are very active, the people there. But in Indonesia, our people, most of them 60s are not very active. What is your experience in France?
In France, there is two types of patients. Patients with rheumatoid arthritis are usually less active than maybe other patient. And if there is no other choice with this totally destroyed joint, I go for total abortoplasty. This is very different in post-traumatic arthritis, where may often the patient are younger or are very active. And I try not to indicate as a first option a total abortoplasty. I try arthroscopy lavage, I've tried some interposition arthroplasties. It's not very reliable, but I try to wait the longer as possible for a total abortoplasty.
Okay. Before I give the opinion, before I give the mic to Professor Cha Soo-min, we have a related question from the floor. There is a question from Sun Gi-ang. What would you offer, Professor Mansar? 45-year-old male manual worker with a symptomatic post-traumatic elbow arthritis of the dominant hand. You will do or not? TR 45.
So depend of the arthritis. If the arthritis is mainly peripheral with some joint line preserve, I will go for an arthroscopic debridement with resection of the osteophyte, with some capsulectomy for a synovectomy, removal of loose body. So I think it will be my first choice. If the joint line is totally destroyed, this is another problem, because we know that the only debridement will be not sufficient. So maybe in these cases we can discuss interposition arthroplasty with fascia lata, or I know in the US they use Achilles tendon. So maybe before doing a total arthroplasty. And I know people are not very kind with the fusion. We know that fusion of the elbow is not good fusion. There is no really compensation possible with the other joint. So depend of the context, but in a very severe traumatic sequela of trauma, maybe with infection complication, I will go for fusion in these very selective cases.
Yeah, it's the same trends in Korea as well. Can I have Professor Soo-min Cha to give a few comments from your side? Please go ahead, Professor Soo-min Cha.
I agree with Professor Mansar, the same opinion.
Okay. Do you have any question you would like to discuss, Professor Soo-min Cha?
I have some questions. Professor Mansar, you have something in doing total elbow arthroplasty, and we have already your numerous publications. I have one question. Your preferred model may be Conrad Murray in your presentation, right?
Yeah.
If there is a difference in choosing the model of total elbowplasty according to the etiology of elbow, such as osteoarthroplasty, rheumatoid arthroplasty, or post-traumatic arthroplasty, if there any preference?
So arthroplasty by etiology.
Yeah.
Do you have a protocol?
You know, we have a history of total elbow arthroplasty in Toulouse. Before me, my father was the chief of the department in Toulouse and was doing elbow arthroplasty. he start with E-World total elbow arthroplasty, then with a non-constrained on a non-linked Guépard prosthesis was famous in France, and he has problems with instability of this prosthesis with time, mainly in rheumatoid patients. Then we tried the GSB3 implant, so it was a linked implant, and at that time I went for my fellowship to work with Dr. Morey, and I learned the Kuhlmann-Morey prosthesis. And when I come back in 1997, I start using the Kuhlmann-Morey, and I feel that it was very reliable in this result and longevity, whatever the indication. Whatever the indication. Rheumatoid arthritis, but also trauma or trauma sequela. So since 1997, we only use the Kuhlmann-Morey prosthesis because we had some problems with unlinked prosthesis before.
Okay, and I have another question. Even though experienced elbow surgeon would not easily perform the total elbow arthroplasty in rheumatoid arthroplasty, thus, do you have considered the activity of the disease before performing total elbow arthroplasty, such as rheumatoid factor or lab data, ESR, CRP, of the period of steroid therapy, or history of recent high-dose steroid, or do you control the steroid dosage before surgery in performing total elbow arthroplasty in rheumatoid arthritis?
So perhaps in the rheumatoid case, usually we have to check everything before we give a procedure. So do you have any red flag for the lab work, such as high ESR, CRP, or would you like to stop the DMARC before you start? Do you give the total elbow replacement to the rheumatoid arthritis cases? Any protocol in particular you would like to start before you gave them the new joint?
Rheumatoid patient with biotherapy, especially, we usually stop the treatment 1 month before a surgery, and we allow them to start again the treatment only after the healing of the incision. So usually it's not more than 1 month after surgery. So we stop the treatment usually 1 month before the arthroplasty, and we allow them to take it again only 1 month after surgery. What about steroid injection? Usually we don't like that rheumatologists do injection of cortisone at least 3 months before the total arthroplasty. So, and do we have a specific checkup before surgery? No, really. It's a standard checkup. No bacteria, only inflammatory checkup and standard checkup.
Okay, so what one is the your waiting time for that to have the new elbow joint? Professor Cha, if I may, can we give the floor some opportunity to ask question for Professor Mansad? We have a question from Professor Edward Ma, Ted Ma. So what did you do, what is your salvage procedure for a failed elbow arthroplasty, Professor Mansad? Salvage.
It's a good question. It's a good question because when you do a surgery, you have always to think about the failure of your procedure and what you do after. So this is one of the main principles in surgery. So first of all, when I do a primary total arthroplasty, I try to use the smallest stem as possible. first, to use cement not over the stem, to keep the cement only around the stem, in order, if I need to revise the stem, I have no problems to remove the cement. So that is the two main principle. After, if there is a failure, depend of the failure, if it's only a loose implant, so it's not too difficult to change, you can change with a longer stem. The problem is if there is some bone missing. If there is some bone missing around the stem, the surgery becomes more difficult, and you need to get some usually allograft, so it can be strut grafts, can be a massive allograft to rebuild the distal humerus around a longer prosthesis. So we have solution until maybe a catastrophic case, that we have solution to revise failed total abortoplasty. But each surgery became more and more complicated, with a higher risk of complication. Yeah.
So we pray not to burn any bridge before we go further. Thank you very much for your time, Professor Mansad and Professor Cha. It was a very wonderful time. I learned a lot. And we have a lot of questions actually from the Q&A section, if you may, and we will be very appreciative if you can answer with this box. And I think good evening in Korea and good day in French. And let's move to the more proximal joint. Can I invite Dr. Mixiang and to our session? Thank you.
Thank you. Okay, it's my pleasure to hold this shoulder session. And my name is Dr. Mixiang, moderator of this session. Came from Chengdu, China, the hometown of joint Pandan. My institute is Sichuan Orthopedic Hospital, and I'm ASEG and ASES member. Before introduce the speaker and the commentator and the presentation, please show the poll question and we try to answer it. The poll question? Yes, I have two poll questions. One, have you managed shoulder OA with anatomic total shoulder arthroplasty in young patients? It's relatively easy to answer, yes or no. I think the most of especially the shoulder surgeon didn't have the experience. So next to the next question. The end. Yes. End of this question. And the next question is how many cases of anatomic total shoulder arthroplasty have you do each year? Yes, I think it's more than 80% of the surgeons have finished the anatomic DSA less than 5 cases. So maybe it's my experience. So it's my honor to introduce, after the polling questions, it's my honor to introduce the speakers and the commentators. And the first speaker is Professor Angus Wallace, the professor of orthopedic and accident surgery University of Rotterdam. The next speaker is Dr. Kotaro Yamakado, orthopedic and sports medicine consultant certified by Japanese Orthopedic Association. And the commentator of this session is Wei Ming Ong, founder member for APOA and ASACA. So the first speaker is from the UK, August Wallace. His topic is anatomic total shoulder arthroplasty pierce and management of shoulder OA in young patients. Please, it's your times.
Thank you very much indeed, Dr. Ming Shan. It is a real delight for me to present at this meeting. Can I just confirm that my slides are up and that you can hear me satisfactorily? Thumbs up if that's okay.
Perfect.
Lovely.
Yes.
My title has changed a little, and we're going to talk about the 10 pearls of knowledge for providing good anatomic shoulder replacement. This is my declaration. I have been a co-inventor of many devices. I am still receiving royalties for the Veos shoulder replacement and the Infinity Lock AC joint stabilization device. My first pearl relates to getting it right first time. In the UK, Tim Briggs introduced the concept that as an orthopedic surgeon, you have a responsibility to your patient to get the operation right. And that means putting it in the correct shoulder, putting it in the right patient, putting it in at the right time, and putting it in the right way. And you as a surgeon have that responsibility. There is a program in the UK, the GIRFT program, that is actually studying all surgeons in the UK to try and encourage them to get it right first time. I'm going to tell you about the monitoring that is carried out in the UK after shoulder replacement. We have a national joint registry, and that joint registry has just this last week produced its 18th annual report. And that report is available as a PDF document, or you can go on to the NGR website and you can look at the results of shoulder replacement carried out across the UK. It is a wonderful development, currently overseen by Tim Wilton, who I worked with in Derby. We now have 3,833 shoulder replacements that have been monitored since 2012. And I'm going to show you some of the results and some of the problems that we have. In 2018, an analysis was carried out of what was happening in the shoulder replacement world. And because people are mixing and matching parts of the shoulder replacement, it was decided to analyze the shoulder replacements according to which construct was used. So you may have one humeral component, but a different glenoid component, etc. As a consequence, we have a lot of different kinds of shoulder replacement. We've got hemiarthroplasties, partial shoulder replacements. We have resurfacing shoulder replacements, and we have both anatomic and reverse total shoulder replacements. And more recently, we've got interpositional arthroplasties. What we have identified is a real problem with the number of surgeons doing shoulder arthroplasty. And this was demonstrated by your poll, which shows that most surgeons in Asia are doing less than 5 shoulder replacements a year. That is not good practice. Shoulder replacements ought to be focused on centers that are doing larger numbers, and that is what is beginning to happen in the UK. You can see in the UK, in 2019, we carried out 7,660 shoulder replacements, but in 2020, these were halved by the COVID problems. Now, if we look at one particular brand construct, that is resurfacing of the humeral head, we have 9 different brand constructs. This makes trying to work out which is the best one difficult and approaching impossible. If we look at the different types of shoulder replacement, you can see that we've got resurfacing, we've got hemiarthroplasty, anatomical total shoulder replacement, and reverse total shoulder replacement. Our joint register has identified 178 different types of shoulder construct. That makes it really difficult to analyze what is a good outcome and what is not a good outcome. Now, it's really important that we identify which are the best. And this list provides our 8-year outcomes from different types of shoulder replacement. The worst outcome is at the top and the best outcome is at the bottom. So stemless humeral head arthroplasty has a 12% failure rate at 8 years. Humeral head resurfacing has about a 10% failure rate. Stemless reverse shoulders are poor. Stemmed humeral hemiarthroplasties are not so good. Stemmed total shoulder replacements are better, and stemless total shoulder replacements appear to be providing even better results. Interpositional arthroplasty, that is the subacromial balloon arthroplasty, has only just come out, and we don't know what's happening to that device. There is a paper that's just been published in the Bone and Joint Journal that analyzes the problem related to knee replacement. And they have demonstrated that there are so many variants now for knee replacement that revision rates of implant combinations are not currently reviewed sufficiently carefully, and some companies are covering up bad results. So we have a problem which is ongoing and for which you as a surgeon remain responsible because you are putting the joint replacement in. So peril number 1, you as a surgeon should know how good the shoulder replacement you are offering to the patient is before you insert it. Do you? I suspect 80% of surgeons don't know how good the results are, either their own results or the results that are published. there is a lot of encouragement at the moment to consider using a personalized shoulder replacement using 3D printing. But beware, personalized shoulder replacements are unique. They have no track record. You do not know how good they will actually perform. Each one is its own individual experiment. L number 4. Never insert a new shoulder replacement without the necessary training. Oops, sorry, let me go back, sorry. It is very important to recognize that if you're trained as a pilot on a 747, you cannot and you are not allowed to fly an Airbus A380. It's a different airplane. It requires different skills. So it is important for you as a surgeon to acquire the skills necessary to put in a shoulder replacement. And you should not be putting in shoulder replacements without adequate training. The surgical approach you've been trained in is probably the best approach for you to carry out a shoulder replacement operation. I use the beach chair position and either the anterolateral approach or the anterosuperior Mackenzie approach. And I use a lesser tuberosity osteotomy that we described in 1989 when we described a special approach for doing revision shoulder replacement where you use a clavicular osteotomy. The lesser tuberosity osteotomy is very helpful for access to the shoulder. You need to use a good position on the operating table, and you need to get good access to the glenoid. Now, it's really important when you're putting in a shoulder replacement to get the humeral head in the right position. And you need to appreciate that the top of the humeral head is 5 millimeters or 6 millimeters above the top of the greater tuberosity. The picture on the right shows a perfectly implanted humeral head. There is, however, a real problem in relation to the potential for overstuffing a shoulder. And it's important to use a thin glenoid component or ream the glenoid or use no glenoid component at all to avoid overstuffing. Rick Matson has described very clearly how you can overstuff in some of his papers, and I would recommend that as a reading. He is a great surgeon, Rick. I have a lot of respect for him. I know him personally. And here you can see in the right bottom picture how an oversized humeral head overstuffs the shoulder. Now, I've been asked to mention young patients, and you've got to decide what a young patient is. Well, a young patient for me today is 71 because I'm 72. But your attitude towards whether you're a young patient or not does change with time. And I think it's reasonable to consider young patients to be under 50. And you've got to think about revision procedures, as was mentioned in the elbow section. You do an operation where the revision can be done more easily. And the ream and run procedure described by Rick Matson for primary shoulder replacement is something that allows you to carry out a revision easily. Now, my advice is that a patient should earn their operation. They should never be offered an immediate operation. They should be offered physiotherapy, painkillers first. The patient should have a period of pain and disability before surgery. You should control the patient expectations and never promise the patient the best result. Ensure they are well informed for surgery. And when you operate, avoid infection. Cutibacterium acnes and coagulase negative staph are the cause of the majority of our infections. And a final tip, don't operate under stress and learn from your mistakes. So these are my 10 pearls for successful anatomic shoulder surgery, and I'm happy to take part in the discussion. Thank you.
Great. Thank you, August Wallace. It's a very excellent presentation. And we will leave the questions and the answer together after the Kotaro. So the next speaker is from Japan. My ASEG brother Kotaro Yamakado. The topic is surgical tips for beginner in anatomic total shoulder arthroplasty. Please.
Thank you, Sam. Is okay? Can you hear me? Okay.
Yeah.
So, thank you. My topic is surgical tips for beginner for anatomic total shoulders. Yep. Oh, yeah. Next. So it's not working. Okay. Okay. So I am from Fukui Prefecture. This is very small town in the Japan. Fortunately, I am the only shoulder surgeon here, so I'm the king of here. So we are all beginners about the anatomic total shoulder. Just the survey says the almost 80% of the participants do only the 5 cases per year. But in the worldwide situations, the shoulder arthroplasty exponentially increasing, especially because of the reverse shoulder arthroplasty. The pace is greater than TK or THAs. If you look at the United States situation, TSA and HEMI is 50,000 per year, and the annual rate is about 10% were increasing. It's amazing. If you look at the European situation, Italy 6,000, German 10,000. But let's go back to the Asian situation. More than half of the world population lives inside this circle. However, anatomic shoulder replacement is very, very rare. If you look at these countries, in Japan, 1,600, China 2,000, India 500. Very small number of anatomic total shoulders. Maybe reverse is much more, but anatomic is very rare. So I can say that anatomic TSA is a rare and a mistakable procedure for all of Asian, all of us. So let's learn together about this difficult operation. First of all, the pre-operative planning is mandatory and very, very important. The pathologic anatomy of a shoulder is according to the modified Walsh classification. Roughly, type A is concentric, type B is eccentric, type C is congenital, and type D is anterior elevate one. Why it is very important? Because accurate component positioning is important for not only the short-term result such as range of motion, function improvement, but also the long-term survival. It is very important. There are lots of debates about the precise number. It's in broad term. Ideal Grenade component position in anatomic total shoulder is superiority to less than 10 degree, axial plane retroversion less than 10 degree, and the component coverage more than 80%. And place the component as high as possible in the Grenade vault. It is a little bit different from the reverse shoulder arthroplasty. For your information, ideal Grenade sphere position in reverse is non-superior tilt. Maybe the neutral to 5 degree in the axial plane, and place the component as low as possible to avoid notching. Again, the ideal granular position in anatomic is superiority less than 10, retroversion less than 10, and the coverage more than 80%, and as high as possible. In the osteoarthritic patient, the posterior erosion is very, very common. There are several countermeasures, high side reaming, off-axis reaming, and bone grafting, especially these. C is very, very rare in Asian situation, I think. In the moderate situation, off-axis reaming is okay. Maybe this is much more for very mild case. If a little bit severe, the eccentric reaming is okay. But because the anterior subcondylar bone should be preserved as much as possible, so the limit is maybe less than 15 degrees. And I should say that perfect correction is not necessary. Again, target retroversion is less than 10 degrees, so no need to perfect correlation, correction about with this kind of techniques. If severe bone graft absolute granular deformity is there, bone graft reverse is okay. But I think in severe case, reverse shoulder would be much easier, much easier than the anatomic shoulder. I do reverse arthroplasty for such cases. And recently, 3D templating software is developed from the several companies. And the researcher says 3D CT is more accurate than plain XP, even accurate than the plain CTs. For example, this is 79-year female. This X-ray looks not so bad, but and also the plain CT is not so bad. But 3D has depicted the impression of 3D images is a little bit different. Much more bone defect is there. So I put in this particular case, I put the augmented anatomical glenoid. So I strongly recommend to use the 3D templating software for this kind of anatomic total shoulder replacement. So let's go to the operating theater. The operation, the arthroplasty shoulder arthroplasty operation is mainly done in vitro position under general or interscalene anesthesia. The critical point is that place the patient as lateral as possible to allow the perfect extension, to allow the perfect adduction of the shoulder. Also place the patient face toward the operative side to avoid the brachial plexus stretching. And also I use an arm stand and wrapping with the stereo map and place my hand on this. I do not use a mechanical arm holder also to avoid the brachial plexus stretching. This is my view, my operating theater. Main camera, main light is from here, the sub is here, and this is the arm stand. I put the stand here. It is very easy to use. This is scrub nurse, this is assistant nurse. Now this is my unit. Also, the light is here, main light is here. And this is my instrument. Maybe this is a little bit cloudy, but maybe it's okay. Next one. Oh, sorry. Also, the deltoid pectoral approach is very popular. Sometimes the gap between deltoid and the pec measure is difficult to find out. The easy trick is find this fat triangle, always on the coracoid process. It is very easy to find out here. From here, the split from superior to distal, it is much easier trick for me and maybe majority of patients, majority of surgeons. And in the anatomic total shoulder, glenoid storage is the key. It does not start from the glenoid side, it starts from the humeral side. The key is accurate humeral bone cut and making haggle. It means enough capsule release on the humeral side and release the adhesions from subdeltoid or subacromial area. And sometimes osteophyte is misleading. You should find out the fat tissue. The osteophyte is always going over the fat tissue. And find the fat tissue, above it, it is osteophyte. And I'll talk about the soft tissue release. Every time joint capsule release, and the majority of case, upper peak measure is cut around 1 or 2 centimeters. Very rare case, coracoacromial arch is released. Very stiff case, I sometimes release the latissimus dorsi, but never ever release the posterior capsule for anatomic total shoulder to avoid the subluxation. This is different from reverse. In reverse, always release the posterior side. And the subscapsular takedown, there are 3 different ways: LTO, peel off, tenotomy, but no clinical difference reported. So it's up to you, surgeon's preference. My preference, tenotomy. It is much easier and quicker. And this is the coagulation of the 3 sisters. They find the group and guided by the long head biceps. Then release the rotator interval here. They cut the subscapularis 1 centimeter medial to the lesser tuberosity. They place the sharp hormone inside the joint and tenting up the capsule and release the inferior capsule. This is fat tissue. The osteophytes is always overgrown over there, and level up with this kind of the ring retractor. The dislocation is done, and this is a hormone retractor upside down. They put the data. This is the dislocation of the shoulder. After the dislocation, the glenoid capsule released from coracoid to 630 or 7. About the number of retractors, less is more, not too much one. The biceps root is excised. The posterior capsule is released, excised. Do not touch the posterior capsule in the anatomic situation. And in this particular case, I put the third retractor just behind the coracoid process. And they put the finger to protect the axial nerve and peel off the capsule here. This is anterior and anterior inferior capsule release. Just do it. Then guide pin is inserted, aiming the Madsen's point here, Dr. Madsen's centering point. They put the guide wire, guide inserter. They put the guide pin. In this particular case, this is a very small B2 glenoid. The gap is here, so I do a very small high side reaming in this patient. If the patient is very stiff shoulder, remove the posterior retractors. Without retractor, it is much easier to use such kind of straight reamers. In severe case, PSI's navigation is very good. This is the B3 glenoid. Very rare, I think, very rare in the anatomic situations. And for beginners and for me, it is very difficult to figure out where the Madsen point is. But this kind of navigation is very helpful. Again, the retroversion is less than 10 degrees, not a perfect correction. The inferior inclination is such number is okay. Also, the flush with the contralateral junction. Professor Wallace says within 5 millimeters. It's sometimes difficult. The easy trick is flush with the contralateral junction up there. Sometimes palpation is not working because the thickness of the supraspinatus tendon. This looks very low, but it is just right. So palpation is sometimes misleading. Also, image intensifies sometimes misleading because of rotation and tilting. So be careful. Be careful about using this kind of image intensifiers. And always, lots of surgeons says that the anatomic total shoulder is a soft tissue operation. The famous rule is 40, 50, 60 rules of Madsen, Dr. Madsen, 40 extension, the 40 external rotation, 50 posterior translation, and the 60 internal rotation. This is called as scarecrow position, or just cut it. The measure cut is put it on the implant sizing. But anyway, avoid too tight. Too tight is too bad. This is 40, 50, 60 rule. 50% of translation, the external rotation 40 degrees, the 60-degree internal rotation is a compression. Maybe it's okay. So this is a through time video. Tenotomy is here. Put this is the Three Sisters area. Remove the capsule. This is a hinge point. The osteophyte is there. Bone cut. Enough bone cut is the key to access the glenoid side. To protect the cutting surface, I always put the metal cover on the cutting surface on it. And after the preparation, I put a very small amount of the cement in the peg. I love the backside cementing. And also I recently use this kind of hybrid glenoid. Just put it on. And recently I do this type of stemless implant. Maybe 80% of my anatomic shoulders. Even with the patient is 80 years old female, I do the stemless. I love that. Because this is very easy operation. The offset is perfectly reconstructed. And this is the key of the sizing. Just put the flash on the condylar junctions. So summary, 3D template is a great help. The key for good glenoid exposure starts from the humeral capsule release. We are all beginners, so go together and further. Thank you very much. That's it. Thank you.
Okay, thank you, Kotaro. Any question and comments from the Wing on?
First of all, I'm Dr. Ng. Thank you, Professor Wallens and Dr. Yamakado for the great lecture. So, so today, I would like to throw a question to both the speakers regarding the glenohumeral arthritis in young patients. If we prefer to do a total shoulder replacement, what is the expected outcome for this group of patients compared to the old patient, and how high is the revision rate?
Can I start with? Oh, so sorry for that.
No.
In total shoulder replacement for young patient, especially less than 40 years old, so what's the expected outcome of the total shoulder in this group of patient, and also how high is the revision rate compared to the older patient?
Because the situation is very different to patient, and if the patient is very, very young and active, I do not put glenoid on, only the hemiarthropathy maybe. And my target is pain relief, and maybe 10 years or later or 15 years later, it must be revised. But I'm not sure the situation is. If the situation not so bad, arthroplasty and arthroscopic debridement or some kind of Professor Miller's operation, such as osteophyte removal. But I think the hemiarthroplasty works very well for this kind of limited goal operations. So I'm not sure the revision rate is. It maybe depend on the patient activity.
Kotaro, the reason you don't know what the revision rate is, that none of us know what the revision rate is. I carried out a lot of total shoulder replacements in my career. I did operate on some young patients. We have monitored the wear of the glenoid, and I used that metal-backed glenoid component for my total shoulder replacements, and the Nottingham glenoid shoulder replacement wears out at about 12 years. I designed it so that you could easily put in a new polyethylene insert, but the company Biomet no longer produces that, which is really disappointing. So I did plan and design for the future for replacing the bearing, but industry has not supported that. And that's really very disappointing. But coming back to Kotaro, I think there is a strong place for hemiarthroplasty in the younger patient rather than total shoulder replacement because of the ease of reoperation. And nowadays, you should consider using a short stem for the hemiarthroplasty. The resurfacing results are not good in the UK. So I think you should use a short stem and an anatomical head.
Right.
So in my opinion, so it's very important to select the proper young patient. So what's your absolute indication for relatively young from your slide? I think is 50 years old, is less than 50 years old, is defined as a young patient. So what's your absolute indication for this patient, especially for the first case for from the beginner in total shoulder arthroplasty?
Kotaro, do you want to go first?
Thank you so much, Professor. The absolute indication is absolutely the arthritic patients, and maybe for beginners the concentric type, maybe A1 or B1 glenoid is a very good candidate for total arthroplasty, total shoulder arthroplasties. B2 or B3 is very difficult. Also, such a rheumatoid patient, A2 is also sometimes very difficult. It is much easier to use the liver shoulder arthroplasty instead of anatomic total shoulders. So I recommend the beginners to start with the concentric glenoid. But unfortunately, the concentric glenoid is sometimes okay to do the hemiarthroplasty. So maybe it depends on the surgeon's preference to choose which is better to do the total instead of the hemiarthroplasty. Professor?
Yes, I have a very serious discussion with my patient. Normally it is a sportsman who has unreasonable expectations, and I have to lower their expectations. I have to explain to them that this is a pain-relieving procedure, that they may go back to their sport, but if they do so, it will shorten the life of the shoulder replacement. So that must be an agreement between the surgeon and the patient. And if they are taking part in high-level sports where they want to have good shoulder function, I would consider a glenoid replacement, but I would first discuss with them whether we should do a hemiarthroplasty, see how they got on, and then add the glenoid later if the hemiarthroplasty wasn't good enough for them. So I would be prepared to do a two-stage procedure in order to try and make the surgery as minimal as possible.
Thank you, Prof. So I think we go back to the surgical tips. For pre-op planning, do you suggest to do a X-ray or imaging of the other contralateral shoulder for comparison or for some measurement before you actually go in to do the surgery?
Not for me. I work in the National Health Service. I need to keep the costs down, and I would only X-ray the other shoulder if there was a particular reason.
Me too. I do not care about the contralateral side because sometimes the retroversion is a little bit different. Also, there is a small information from the contralateral side, so I do not feel necessity to take the contralateral side of exercise.
Okay. Is there any tips to do a proper repair of the GT or LT fragment, the bony fragment, in order to get a better range of motion and result? Is there any better, what suture you use to repair it, and how you position the fragment? Is there any landmark reference to you add on bone graft on that fragment?
Sorry, I did not understand the question. Can you say it again?
Maybe Professor, he asked about the repair technique of lesser tuberosity osteotomy.
Yeah.
I use sutures that are placed around the bicipital groove. So I go through the subscapularis tendon, around the bicipital groove, and tie 3 sutures together to bring the lesser tuberosity back onto its anatomical position.
For lesser tuberosity osteotomy, I always keep my mind to control the height of the fragment. Sometimes after the tying the knot, the fragment is a little bit shifted higher or the lower. So I always tying the superior part, or maybe the rotator interval, and that for temporary. And after that, I suturing the main part of, just like the professors. And also for doing the lesser tuberous osteotomy, I always keep my mind to take the very small amount of the lesser tuberosity fragment. If the fragment is too large, it interferes with, especially for the small shorter stems. Then also for the stemless system, the hoop stems is jeopardized after the large fragment is created. So that's why I use and I switched from lesser tuberosity to tenotomy, maybe 20 years later. That's it.
Kotaro, there has been a recent paper that shows that the lesser tuberosity osteotomy is superior to doing a tenotomy. But
I haven't. Yeah, is it real?
Yeah.
Oh yeah.
There is. I can't remember who was the author. Ming Zhan, I have a question. I know that Jonathan Phillips has joined us in the audience. I don't know whether it's possible for him to tell us how difficult analyzing the knee replacements are on the National Joint Registry in the UK. Can your team give him speech access? I think he may have it. Jonathan.
Can you hear me?
Yes.
Yeah, oh, thank you. So thank you for inviting me at reasonably short notice. We just had a paper published in the BJJ this month, and I'm part of the ODEP team that analyzes information provided to us by companies in order to give implants ratings for knee replacements. And ODEP has been working for shoulders for quite some time now. One of the challenges we found was that you can only really provide ratings on implants that are performed frequently and in reasonably large numbers. But when you look at some of the more established knee brand options, you realize that there are many, many, many options that can be used. And I think you touched on this in your presentation, Professor. So there are some knee implants that have 6 different compatible tibial trays, 6 different inserts in different plastic configurations or manufacturing types, fixed bearing, mobile bearing, different femoral components. They often have 5 or 6 different femoral components. And then you have cemented and uncemented patellas and unccemented and cemented implants. And then you have the ability to have hybrids. And we put together, just basically the paper was really just a matter of putting together the numbers. And you established that if you have 2 of each type, then basically you have over 190 different potential combinations of implants. And then this raises the possibility of camouflage, which is where an implant that is performing poorly might be camouflaged by a larger data set by implant combinations that are doing well. So you might find that, and I know this is certainly a pertinent problem for shoulders because you have glenoids with different angles and there are lots of different options and combinations. So the numbers, certainly for some of these variants, are staggering and are likely to be in the tens of thousands of different construct combinations you can have. And what we don't know is that some combinations of implants are probably going to be worse than others. So you might have, a different allergy-free shoulder replacement with a funny glenoid facing the wrong direction. And you might find that 100% of these fail, but they've only been put in 5 people. And the National Joint Registry analysis doesn't look at that level of granularity. So there is this potential that you have implant combinations within a very well performing brand that are not doing well. And we've raised...
Jonathan, I'm going to cut you off there. You've got your message across, and I'm really grateful that you have. We need to focus on shoulders, but that is a really important message, and I think the audience need to understand this. We don't really know what the results of the new shoulder replacements are, and it's going to be really difficult to monitor them in future. So thank you for joining us.
No, thank you for the invite. Thank you. It's been very interesting.
Ming Shan, back to you.
Just one more question is, there's last 2 years, I think the French Shoulder Society have published their outcome study for reverse shoulder replacement. They really give a boost for the outcome of reverse shoulder replacement in all aspects, more superior than the total shoulder replacement. What is the opinion of the speaker regarding this study?
Kataro, you go first.
Thank you so much, Professor. I think the reverse is okay, but not super operation because range of motion is not so super, flexion is not super, external rotation is not super, internal rotation is sometimes miserable. Anatomic is always better than reverse if the proper patient is selected. But if the patient has some rotator deficiency, if the patient has lots of bone grafting, maybe reverse is much more superior than the anatomic, but always choosing the right patient. Anatomic is better than reverse.
Okay. My view, the reverse is a good implant for the old patient, and that would be somebody who is 80 or older. I would not put a reverse into somebody who was younger than 50 unless I was in a really difficult situation. So I think the anatomic for the younger patient, and then you have the middle group where you need to discuss with the patient what they want to do. We do not know what the long-term outcome for the reverse is beyond 10 years. We know up to 10 years it's good. We don't know beyond 10 years.
Thank you.
Okay, the time is out. Thanks, gentlemen, for sharing with your experience, concept, and the surgical tips of the anatomic total shoulder arthroplasty. Thank you so much. And let's hand over to the Edward Ma.
Thank you so much, gentlemen. Can I have the, just want to thank, first of all, for all the speakers who have provided so much information and very interesting discussion tonight. I'd like to thank Alphonsus Chong from Singapore, UT Lin from Taiwan, our friend Pierre Mansart from Paris in France, very good friend Angus Wallace in UK, and Kataro Yamakado. Thank you also for the commentators and and moderators who are helping the sessions. I'd like to thank our Auto TV who are helping us in broadcasting these events. And this is our committee members. By the way, the association, the Hannah Lim Society, is actually a fairly new organization, started only in May of 2020 during the COVID period. We have 14 country members and now about 16 now. And I urge all of you who are not members to join us in this interesting society who the main focus really is on education. We run several webinars a year, roughly about 4 or 5. In fact, next year we have 5 webinars. And I would like to invite In Ho Cheong, the incoming president, to tell you about the webinar for next year. Of course, these sessions will not be possible without our sponsor, who is Stryker and our sponsor. In Ho, would you like to talk about the 6th webinar in 2022?
Oh, sure. Thank you very much, Ted. Thank you very much for all the speakers and the moderators. And I also do appreciate all the participants until this time. Again, we have a very interesting webinar planned next year, January 29th, Saturday, same time, 5 p.m. KL time. If you'd like to update any knowledge and experience on upper limb nerve entrapment, this is the best chance. We can cover arthroscopic open suprascapular nerve entrapment in the shoulder, and we will introduce you a very interesting mini open or endoscopic assisted cubital tunnel release, and also open or endoscopic carpal tunnel release, and how to do a revision surgery. This is very interesting topics which you can apply to your clinical setting right after webinar. So I welcome you all, especially those under a training scheme. This is going to be a very instructive webinar for you. Thank you. Over to you, Ted.
Thank you, In Ho. Also, our committee member, Margaret from Hong Kong, is chairing the Hong Kong University meeting in November this year. And I'd like Margaret to tell us briefly about this meeting, invite all the audience to join this session. I believe it's free for people joining. Margaret, over to you.
Thank you, Ted. So this is the 60th anniversary of the setting up of the Department of Orthopedics and Traumatology of the University of Hong Kong. So we are celebrating this, and we are combining our 60th anniversary scientific meeting with our 17th Hong Kong International Orthopedic Forum. So, and we are very lucky that we are going to have a session that is co-organized with the APOA hand and upper limb session. So you can see that it's not just about upper limb. We have different invited speakers from all over the world that talk about everything, including joint replacement, trauma, oncology, and spine. So for our session, and you can scan the QR code here for registration, and any overseas speakers, any overseas participants will be free. So you just need to take this opportunity and enjoy the early bird offer by the 8th of October. So the next slide, please. So for our APOA session, it will be on the Saturday, which is on a Sunday, which is on the 28th of November. It's in the afternoon for the Asia people, but early morning for the European, and very in the middle of the night, basically for the North American. So we have the hand and wrist sessions, which we have on many different topics, including duplicitous contracture, adolescents, wrist injuries, and the first CMC joint. Then we followed by the elbow and shoulder session, which is we're going to talk about elbow osteoarthritis, elbow instability, and as well as and shoulder, including reconstruction. So I would like all of you to join this, and yes, and to join our session. Thank you. So over to you.
Thank you, Margaret. So again, the next slide, please. So finally, I'd like to thank everyone who participated in this session, in particular supporting staff, both our Zoom organization as well as Auto TV. As I mentioned, there are many sessions many webinar next year, starting in January. In fact, we will have a combined session with the trauma section of APOA at one stage, and also a annual ASM AGM meeting in November in Manila next year. Hopefully, there will be a face-to-face and a combined face-to-face and hybrid meeting. Please complete your questionnaire at the end of this session so they can get a certificate of attendance. People who inquire whether they would be recorded session, it is a recorded session that you can get access to after this. For those of you who are not members yet, I urge you to join us as a new member for the association. And you can do that by following our social media, scan this code, and you can then follow our future sessions as well. To that, I thank you all for attending and good night.
Thank you.
Bye-bye.
Thank you.
Bye.
Thank you.
Just a reminder for the committee members, there will be a brief review of these sessions with a different Zoom login. In Ho Cheong has already provided us with the login details earlier.